Hi, welcome to Asthma Lecture No. 2. In order to assess acute severe asthma, we have to follow some criteria. In acute severe asthma, peak expiratory flow ranges 33 to 50% predicted, heart rate 110, or more than that. Also respiratory rate in 25 breaths per minute, or more than that. And the patient will not be able to complete sentence in one breath. Life-threatening features include PEF less than 33%. Oxygen saturation less than 92% after being treated with oxygen. Cyanosis, feeble respiration. Other features are normal or raised partial pressure of carbon dioxide, silent chest, bradycardia or arrhythmia, hypotension, exhaustion, delirium, coma. Patient with neonatal asthma presents with raised partial pressure of carbon dioxide and/or requiring mechanical ventilation with raised inflation pressures. Treatment of acute severe asthma depends on peak expiratory flow rate, which is measured and converted into percent best or predicted. Patient with 76 to 100% PEF is in mild asthma category. In this kind of patient, history about taking nebulization before PEF record should be taken. If no history, usual bronchodilator and wait for 60 minutes. If symptoms improve, they will receive usual treatment at home and consult doctor if gets worse. In moderate category, arterial blood gas analysis is done. Treatment with salbutamol or terbutaline nebulization. High-flow oxygen. 40 mg prednisolone orally is given. And wait for 30 minutes. Measure PF again. In life-threatening conditions, protocol is almost same as moderate asthma. Intravenous hydrocortisone 200 mg is preferred instead of oral drug. Then intravenous access, chest X-ray, plasma theophylline and potassium level is measured. Admit the patient and manage with nebulized salbutamol, ipratropium bromide. Oxygen-driven nebulizer is used. Intravenous magnesium sulfate is given. Also fluid and electrolytes are corrected, especially potassium. Now if the patient is nebulized before PEF record, wait for 30 minutes and measure PEF again. If greater than 60% predicted, 40 mg oral prednisolone for 5 days. Double inhaled steroid are given. Consult with general practitioner within 48 hours. If the PEF is less than 60% predicted, life-threatening conditions treatment protocol is followed. Assisted ventilation is recommended if the patient present with fatigue, exhaustion, altered mental status like confusion and drowsiness, respiratory arrest. Partial pressure of carbon dioxide is greater than 6 kPa and rising, with low and falling pH. Patient with marked intercostal and suprasternal retractions. Falling partial pressure of oxygen and poor treatment response is also recommended. Levels of asthma control. Controlled patient will face no daytime and nighttime symptoms. There is no need for reliever treatment and no limitation of daily activity. Lung function test is normal with no exacerbation. Partially controlled patient present daytime symptoms more than twice per week. Nocturnal symptoms and limitations of daily activity occur. Reliever treatment is needed for more than twice per week. Lung function is less than 80% predicted and exacerbation is once or more than once per year. Uncontrolled patient will present 3 or more than 3 features of partially controlled asthma in any week. Exacerbation once in a week will be present. Prognostic criteria. Nebulization discontinued for 24 hours with PEF 75% of predicted or personal best. Before releasing, advice on avoidance of triggering factor. Asthma education. Follow-up at specialized center or visiting general practitioner and written self-management of asthma is given. Subscribe for more.